complex, PR segment. Ending of the QRS complex, starting from the T wave, is the ST segment. PR interval, starting of the P wave and starting before the Q wave is called the PR interval, and QT interval is starting from the QRS complex to the end of the
T waves.
wave, because this is the total ventricular action. Okay, this is the total ventricular action, that is called the QT interval, and this is called the QRS complex. This all you have to remember, and is going to tell you what is happening in the SA and AV node and the ventricular polarization, repolarization. Okay, so now first wave produced by electrical impulse from SA node is P wave. It's smooth, rounded, upward deflection. What is happens? Why it causes? Is caused due to the depolarization of left and right atria. So P wave is equal to depolarization of left and right atria. What it does? SA node triggers the signals. Remember, when the SA node triggers the signals, it goes to the internodal pathway to both atrias, and later it go to the AV node. But first it started the contraction of the atria. This contraction caused the depolarization of the atrium. This depolarization caused this waveform. It's called the P wave.
Miss, we're not hearing you.
Yes.
Hello? Hello? Hello?
Hello, ma'am. Hello.
Yes, you're back.
Hello?
Hi, Miss. You're back.
Hello, back? I'm
You're
back.
back.
Yeah, you're back.
Okay. So how many times it takes? 0.10 second, 0.1 seconds. Means it's going to cover how many squares? P wave. If it's 0.1 seconds, how many squares is going to cover? Small squares.
0.1. 5.
No,
3.
no. If one square is 0.04,
Yeah. Oh, yes. 0.04. It will be around 4 point something. 0.045.
0.1 second is going to cover how many squares? One square is 0.04.
2.5.
2.5.
Yeah.
2.5. So see, 1, 2.5. Starting from here. So you can see 1, 2.5. 0.004, 0.04, and if half of the square is 0.02.
So can we write as 0.25?
What?
Do we write it as 0.25?
How it is
then?
0.25? How you are going to count 0.25? Where is comes 0.25?
Are we timesing the squares?
Squares takes 0.04 second. Where is coming 0.25? 2.5, not 2.5. 2.5 squares covered.
Okay.
Squares cover 1, 2.5, so 2.5, not 0.25. Squares, 1 square, 2 squares and half, 2 squares and half. 2.5 squares is covered by 0.1 second. So generally P wave covers 2.5 squares and takes 0.1 second. Do these calculations. Make it very clear in your brain. Now the PR interval. What we told you, PR interval is the time when the PR wave is starting and the QRS complex is beginning, right? So it takes place 0.12 to 2.02 seconds in length. So time impulse travels from SA node through the internodal pathways in atria towards the ventricle. So it is interval from start of P wave to the start of QRS, what I told you here, PR interval. Starting of P wave and before the starting of QRS complex, that is the PR interval. This is from here to here. The QRS complex is going to start here. So from here to here is called the PR interval. Why this small time is taking? This time is taking. Why is not immediately starting the QRS complex? Why this interval or the PR segment? This area is called the PR segment. Why this is? Because you remember first the sinoatrial node send the signals here. Atria contracts. When the atria contracts, tricapsid, bicapsid valves open, and it takes some time, little bit time, fraction to fill up the ventricles. If it transmits the signals instantly to AV node, what is going to happen? The ventricles are not going to fill up properly and it is going to start contracting because immediately the signal is going to pass from here through the AV node to the ultimate to the Purkinje fibers. So there is a little bit delay. SA node immediately send the signals to the atrium. Then it takes a little bit time to signal to the AV node because the ventricles needs to be filled up. When the atria contracts, these valves open, tricapsid, bicapsid, then the ventricle is filling from the atrial chambers. To give the time to the fill the ventricles, there is a little bit delay. That's the in segment is called. So the time starts from the P wave to the start of the QRS. So this time is the time when there is a question why there is a delay in the signal sent from SA nodes to AV nodes. Answer, to fill up the ventricles. Each point, each question is important for your exam and for your knowledge. You can forget all these things after your exam is done, your graduation is done, or the MLPAW is done, till MLPAW. But this is generally time takes 0.12 to 0.0 seconds for the P interval. That is the
Yes.
normal range of the. I lost the connection?
Yes, miss.
No connection?
No. I'm listening, but I have a question.
Okay.
No, you were asking a question about why is I missed that question just now. You asked a question, why is the something another? I'm not quite sure because I missed that question. Fill up something.
Ventricle.
Is the ventricle.
What was the
the-
question, miss?
Yeah. Delay of
is
the
the filling
SA
of the
node to AV
ventricles.
node
Yeah.
What was
to
that?
fill up.
Sorry.
The delay of the signals from SA node to AV node.
AV node, yeah.
Okay, thanks.
So delay is so that the ventricles can be filled up from the blood from the atrium.
Mhm.
Thank you.
Okay. Next, we have the QRX complex. QRX complex means now SA node send the signals to the AV node and AV node starts its action. So immediately send the signals to the bundle of His, then left and right branches, then to the Purkinje fibers. When it's done, ventricle contraction started, these two valves closed, right? And during the contraction, the specific valves which goes to the specific areas from the right ventricle, it goes to the pulmonary artery, and from the left ventricle is go to the aorta. So when it contracts, this is the contraction or the ventricular depolarization. Contraction means systole. So due to the ventricle systole, during the ventricular depolarization, this QRX complex takes place. So what is represent? It represents conduction of
Hearing you. Disconnect.
You again.
You're gone again.
Miss, are you there? Bad connection again. We can't hear you.
You want somebody to send her a link.
She's in.
Oh, she said, send me a link. Using data. Send me a link. Yeah. Did someone send her a link?
She's already in.
Okay, good.
Yeah, she's in. Shows she's in.
Okay, good. Awesome.
She lost again. Okay.
Verna, are you sending, ma'am?
Yeah,
The link?
yes, yes. Calling her. But she's not picking up. Oh, she's there.
Can you hear me now?
Yes, ma'am.
Yes, ma'am.
Yes,
Oh
ma'am.
Yes,
my God.
miss.
I'm so depressed today. I'm using data in the WhatsApp to send you the message. Yeah, okay. It's showing the Wi-Fi is on, looking very bright, but what is happening, I don't know. Signal from the through the AV node to the Purkinje fibers, contraction of the ventricle happens on the sequences happens, and it forms these waveforms. So ventricular depolarization, it first goes a little bit negative deflection, then it goes up, positive deflection, then it's going to, so this is the Q, this area is total R, this is the, and this is called the QRS complex, the total. That is the total QRX complex. Q starting R top is at the base. always S goes in the, again, go to the positive deflection, and then is going to the negative and going to the, come to the baseline. This is the ventricular depolarization. So QRS complex represent the ventricular depolarization. So Q wave, first downward deflection, R wave, first upward deflection. That's the largest deflection seen in the leads 1 and 2. So this represents the lead.
We can hear you again, ma'am.
We lost you again.
She's in now.
Can you hear me?
Yes, mom, we can hear
Yes.
you.
Oh my God, I'm so upset today. This is a so important chapter and it's giving me so much trouble.
It's okay, miss. It's one of those days.
Exactly.
Oh my God. So
Yeah.
basically this is we have done, and it takes generally 0.12 second. That
We're
means
not seeing your
only,
slide, miss.
huh?
We're not seeing your slide.
I did share. Oh, this is a new one. Sorry. Share. You can see now?
No.
Okay. One or the other problem. So it also takes 0.12 seconds. Okay. So that means 2.5 squares. Right? Is that right?
Sorry,
Can you
miss,
hear-
we can't
Yeah,
see
but
you.
0.012 seconds, but we're not seeing your slides.
Yeah.
And I have a question. I just wanted to know for sure which is the Q wave versus the R and the S, because I know the Q is saying that it's going downward, but also
Can you see
the
my slide now?
no, I'm
No,
not seeing
ma'am,
your
we
No.
can't see it.
It's showing the sharing, but why it's not showing you guys? My goodness.
It's okay.
Can you open your slides now so that I can go through yours, slide number 40? In
Yeah,
your computer, you can open yours and I'm going to talk from here.
yes,
Okay,
mom.
miss.
I
Okay, you
can
can
all.
do that.
Did it?
Yeah, yes, ma'am.
So we are here, slide number 40. Okay. Everybody opened it, slide number 40. Hello?
Yes.
Yes, miss.
Yes.
Yes, it's
I
open.
am so stressed out now. Probably I can think you guys are not cannot hear me. I'm stressed out.
Oh,
Oh, we
So
can
we're
see your
We
now.
can
slide
see
now.
you. We can see
Miss,
you.
we can see your
We can
screen
see
You
now.
you.
see yours now. Awesome.
yeah.
Okay. See, this is also what was Asnet's question?
I wanted to know from the graph, which is identified as the Q wave. I see it saying first downward deflection, but is this the darker one? That's the
This
Q?
one, where I'm moving my slide.
Okay, that's a Q.
Mhm. This is
And
the
then the
R.
R is,
R.
okay, that's the R.
R is the
Okay.
This is
longest one.
S.
Okay,
This
good.
downward
Awesome.
duplication, this
Just
is
wanted
the
to know
S.
the Q.
It's okay?
Okay, thank you, miss. Yeah,
Okay,
thank you,
no
miss.
problem. So now we are telling about the J point. Now you know the P wave, you know the R wave, you know the Q wave, S wave, right? So always Q or S always
Yeah, okay. I was just
P
taking
wave
one
comes as a
video
single.
that recently.
Okay. Can you hear me now? Hello?
Yes, ma'am, we can hear
Yes,
you.
ma'am.
Yes, we're
Okay.
hearing you.
Yes, we hear
Okay.
you.
Okay. So then after this QRS, it comes to the baseline. These are called the baseline, right? So this is the negative deflection, positive deflection R. Then S wave goes a little bit negative deflection. Then it comes here in the baseline. And then it started for the T wave. This is called the J point. This is the name of the when the S wave meets with the T wave, beginning of the T wave, ending of S wave, and the T wave is called the J point. Okay, so consideration of ST segment. This is called the ST segment, right? This is the ending of the S and this is the beginning of the T. So it's called the ST segment. Consideration of ST segment elevation or depression begins with the analysis of the J point. So this is the area is very crucial. It's the J point. J point is where QRS meets ST segment. This is the ST segment is making. So this is the ST segment where the point where the ST segment QRS meets the ST segment. This is the segment, sorry, and this is the meeting point of the QRS with ST segment. So ST segment, this is the time interval during which ventricular depolarized and repolarization of ventricles begin. So this is the, it not even immediately, right? So this is the area, what happened, the ST segment, ventricular in the depolarization, QRS complex, ventricle depolarizes, means ventricle contracts. Now ventricle has to relax. When it's relaxing, this is the area it's happening the both things. Ventricle contraction is going away and started the relaxation. So this is called the depolarization of the ventricle ends and repolarization, that is the relaxation of the ventricles begin. So ventricular time during which ventricle depolarized and repolarization of the ventricles begin. This is called the ST segment. This is the point QRS complex completely ventricle depolarized. ST segment is the junction where the depolarization ends and repolarization begins. So this is the depolarization and repolarization of ventricles occurs in the ST segment. And TOF is called the ventricular total repolarization or the resting phase. So isoelectric are consistent with the baseline always. She's always giving you the time. What is the time? Next is the T wave. It follows the ST segment. So this is the ST segment. And then after that, the T waves come. T waves is ventricular repolarization. Ventricles is going back to its relaxing phase. You can see it's getting relaxed. Here you can see ventricle is squeezed, contraction, then is getting relaxation when is going to the formation of the T wave. For studying, for learning, it's taking hours and hours, but when it does, couple of seconds, one cardiac cycle. So follows ST segment, represent ventricular repolarization, is slightly rounded, and it has the positive duplication. And this is the resting phase of the cardiac cycle when no activity is going on. There is no electrical activity. It's repolarization for everything. If this lasts for a long time, what is going to happen? If the T wave it takes long time, that means heart cannot start up. There is a problem in the pacemaker. There is a delay in the starting up. So each wave has its each importance. So QT interval, as we told you, is at the beginning of the QRX complex to the end of the T wave. That is the total ventricular activity. Represent all ventricular activity. That means ventricular depolarization and ventricular repolarization. So QT interval represent the total ventricular activity, and its generally can stay from 0.28 to 0.44 second. These seconds are not important for you guys to remember, but that's for your interest or knowledge we are telling you. But you have to remember QR interval represents the all ventricular activity. POA represent atrial depolarization or atrial activity. QRX complex, it represent the ventricular depolarization. TOF represent ventricular repolarization. QT interval represent the total ventricular activity. That means depolarization and repolarization. You can see this is the abnormal prolonged TOA, taking long time to hearts became to the resting state. That means ventricular muscle cannot is some problem. Sometimes this wave called the E wave, it generally doesn't come. It generally doesn't show in the normal ECG. But sometimes it comes, sorry, if there is a present, it should be 1/3 of the T wave if there is present. If there is present in the normal is third. But if these waves become higher, there is a problem in the electrolyte imbalance. Sometimes it represents the low sodium. These questions comes. If there is a, you saw a U wave, U wave, tall U wave, what that means? It indicates electrolyte imbalance, mainly low sodium in the blood or the hypocalcemia. It can give you that if there is hypocalcemia
Potassium.
type of waves, you can see low potassium. If there is hypocalcemia, what type of waves you can see? They can give you T wave, E wave, D wave, B wave, P wave, whatever, and U wave. So you can see the U wave, taller U wave. U wave generally presents when there is an electrolyte imbalance. Even it's normally present, it should be 1/3 of the volume of that. So it's almost negligible to see. But taller U wave means there is a problem, is mainly when there is a low potassium content in the blood, it gives you the U wave. So how the U wave looks like in the hypocalcemia, you can see how big it is. U wave, T wave and U wave is almost same. U wave is longer than the T wave. U wave is longer than the T wave. So this is the T wave, this is the T wave, okay? So this is the V4 and V5 lead. So you can see the hypocalcemia. Generally, these waves doesn't present in the normal ECG. But when these waves appears in the ECG, immediately doctors can understand there is a low potassium in the blood and the blood report is also going to say me that then they have to monitor the potassium therapy. Okay, so 12 leads 1, 2, 3. QRS is a positive deflection. 1, 2, 3. QRS is in a positive deflection. 1, 2, 3. AVR, QRS in a negative deflection. What is the AVR? So it's going to show you the negative deflection. It's negative deflection in that is recording in the opposite side. That's why it doesn't mean it's a heart problem. So it's going to show in the graph the negative deflection. So in AVR only is going to show you the negative deflection, and AVR and QRS is a biphasic. Biphasic is going up and down.
Miss, we can't hear you again. Should I add her again?
Yeah, can't hear ma'am again.
Yeah, I'm gonna add her again.
Yeah, might as well add her again.
Yeah.
Let's see.
Okay. Okay, I think she's back.
Oh, she
Is she
just left
back?
again.
Oh God.
Yeah.
Okay, I'm gonna get her to request to join again.
Is that?
Yeah, I think she's back. Miss Manman, you're on mute, so we can't hear you.
You can see my slide now?
Yes, you're back.
Okay.
Yes.
Okay. Thank you. So immediately when you cannot hear me, just send me a response. Okay, link. Okay. That we can do. So this is the thing. This is the chart. It's not, you doesn't need to remember that much. It's very complicated. But yeah, it says that you can just remember number 1, 2, and 3. What is the standard leaves or limb leaves? They give the positive deflection for the QRS complex, only QRS complex. What is the AVR? Which is this one? AVR is going to, I cannot see in my eyes. So this is AVL. This is AVR. AVR going to give you the negative deflection. Okay, because it's going from there to there, negative deflection. I don't understand all this why it's going on, but this is going to give you this type of picture, negative deflection. This one, AVL, is the biphasic. You can see it's go up and down, same way. And AVF also give the positive deflection. So only remember that AVR gives QRS a negative deflection and AVL gives a biphasic. That's all. All are giving you positive deflection. R gives the QRS positive deflection, negative deflection, and AVL is the biphasic. That's just remember from this graph. You doesn't remember all others are giving the positive deflection. So V1 negative deflection. This you doesn't remember to remember. It's too much. So here I can see what it sells. AVR is giving the QRS negative deflection, AVL is giving the positive deflection, and AVS gives the biphasic. It's not too high, too long. See, you can up and down is the same. This is called the biphasic. Okay. Here you can see the positive, negative deflection. Going to total after the, this is the, let me make it a little bit bigger. So if this is the baseline, this is the baseline, right? This is the baseline. It is giving the AVR is giving the negative deflection. When the AVR started, is giving the negative deflection. AVL is giving the positive deflection from here to here. And this one is biphasic. You can see how it's giving you top and same. This is called the biphasic. Okay. This we already told about Intofen's triangle and law. Intofen's law is stating lead 2 is equal to lead 1 plus lead 3. 1 is going, and they are all the bipolar leads, limb leads, bipolar leads. So review the tracing on the last slide and count the positive deflection on the 3 main leads, lead 1, 2, and 3. Does it follow the rule? You can do that later. Okay, so lead 1, 2, and 3, and then you can see lead 1 and plus lead 2 is equal to whether lead 3 or not. That is your home task. So summary of the waveforms: P wave, arterial depolarization; QRX complex, ventricular depolarization and arterial repolarization; T wave, ventricular repolarization. Artifacts. There are a lot of artifacts comes in the ECG. So what is the time now? It's okay. We can couple of minutes. Artifacts are artificial or abnormal recordings which is picked up during the ECG due to for different problems. Which the electrical activity is picking up different aspects. So artifacts indicates that there is a technical problem with either the patient setup or with the ECG instrument itself. What are the different types of artifacts? When the patient is moving too much. Sometimes even you are doing the ECG, patient is moving, doing this and that. Sometimes it's giving you this type of tracing. So from this tracing, you can understand this is the muscle, because all tracing is abnormal. So this is called the muscle or somatic tremor. So somatic tremor and this type of artifact is going to be seen when you see in the ECG paper. You see the muscle or somatic tremor. When you do the ECG, you can see, you can look. If you move your hand, how the tracing looks like. You will understand from there. So muscle artifact, these are the erratic spikes of varying size that can interpret waveforms of the baseline. So erratic size spikes, no similarity, nothing is erratic. So person movement is not constant, it's a constant motion on constant ways moving. So erratic spikes of varying size that can entrapped waveforms of the baseline. So this is the, who is the source? The patient is the main source, usually found only in the affected areas, because you are not going to move your beds and other things is not earthquake or anything. What should be the cause of the muscle? The patient itself, right? So patient is the source, usually found only in the affected leads. What are the causes? Any patient movement, muscle tension or rigidity, if the patient has chills, if has any nervous disorders like Parkinson's or any nervous, the patient, mainly the you can see the somatic tremors. Patients are shivering or always moving. So these are the cause. It can show in the as a muscle artifact in the ECG. So what are the troubleshooting? Ensure the patient is relaxed and comfortable as much as possible. If the patient is moving or something or any problem, keep all body parts well supported on the bed. So it's not one is hanging, one is like that. So all is nicely placed on the bed. Ask patient to place their hands under the buttocks to reduce the involuntary shaking. You like the Parkinson patients, you cannot control it, right? They are going to move. But if you put the patient's hands under your buttocks, it's going to be the less shaking. So you are not going to get that much artifact. If the patient is chills, just cover them up. check limb sensor position and move to a position that it is not tremorous or upper arm. Example, upper arm. Upper arm is not shaking. Move limb sensor to torso if tremors cannot be controlled. Limb sensor, that is they make the
Miss, we
Can't hear you
cannot
again,
hear,
ma'am.
cannot hear you again, and it's break time. Can someone add Miss back before we go on break, please?
Yes, I'm adding her.
Thank you, my dear.
Yeah,
No
it's break
problem.
time. You are so right. That's it.
Yep. My brain is
But
overloaded
it shows
too.
she's in the meeting, so I can't even re-invite
Yeah,
her.
it's really overloading. The
Mhm.
ABR, ABL, ABF,
Yes.
Okay, I'm
QRS.
gonna actually remove
The
her from the meeting and then
QRS.
add her again.
Yeah,
Okay.
okay. Thank you, Shabana.
No worries.
It's good when we have an IT girl on the line, you know?
Yes.
For sure.
Okay, she's back again.
She's back, I think.
Okay,
Yeah.
perfect.
Miss, are you there?
It's on mute.
As,
Yep. Okay, you're
Asnet,
good
I
now.
understand is a break time. You told that break time that I can hear you, but you can, yeah. So let me just complete this muscle artifacts. Then you are going to the Wandering baseline, okay? Muscle
You know,
artifacts is, yeah.
Okay, ma'am.
So anything, any kind of tumor or anything. So you have to, sometimes you have to move the
we're not hearing you
We
again.
lost you again, Miss.
Yeah, can't hear you again, ma'am.
I think the system need a break too.
Yeah, I guess so.
Yeah, today is really bad with the system. Crazy.
Yeah, it is.
Are we adding her again?
Lost, ma'am, again.
Yes, I'm gonna try to. No, she's
think
still
she's-
Oh,
connected.
she's here.
She's
Wait,
back.
she's
Yeah,
here.
she's here
back.
now. Okay, yeah.
Let's go for a
Can you
break.
hear me?
Yes,
you
No,
hear
I just
me?
Miss.
messaged
Yeah,
in the
I
group
hear you
saying
now,
go for a
Miss.
Okay,
break.
okay. So I just go for, yeah, just muscle artifact continue. This is the muscle artifact looks like. So what will so okay. We are going to start from the wandering baseline, go for break. And after 30 minutes, if you doesn't see me, I cannot join,
Invite
just send
you.
me the link again, okay? Send me the link,
Okay,
Okay,
okay?
ma'am.
I'll send you a link.
Okay.
It's
I am extremely sorry or
11:05.
apologize, but it's not in my hand.
No worries.
We
So it's
understand.
okay
okay,
if you
ma'am.
just
Okay.
send you at
Okay.
11:30
Okay.
Okay,
or
Miss.
11:35. Yep.
11:35, yes.
Okay.
Thank you. Have a good lunch.
Okay.
Thank you.
Okay, thank you.
Yeah, thank you.
Can you hear me? Hello?
Yes,
Yes,
Oh my
ma'am.
Yes,
God.
miss,
ma'am,
we
we
can
can
hear
Oh
hear
my
you.
God, the computer needs a break. Okay, should we back? You can see my screen too? You can see my
Yes,
screen?
miss.
Yes, ma'am.
Yes.
Thanks.
Okay. So we have talked about so you have a good lunch now, everybody? Brain is source of full of energy, sugar, everything.
Yes, miss.
Okay. So I have by this time probably will get it. I have sent you the ECG review.
Oh,
Test one.
yes, ma'am. Thank you.
Yes, I received it. Thank you.
Okay, yeah, even maybe we are till need to learn something, but I send you whatever you have learned so that you can work on that, okay?
Thank you,
Okay.
ma'am.
Okay, so muscle artifacts, we already know that. How it's going to be is that it's going to be irregular spikes. Like that is the
Mom, you're gone again.
We can hear you again, ma'am.
Okay, let me try to add her again, guys.
Okay.
Is she in?
Yes, she's in.
Yeah, that's what's mine showing as well. Oh no, I think
okay,
she. Okay, there you
okay,
go.
okay. So wandering baseline, when is climbing the wander, it's not going to be very straight. It is not, the baselines are not straight. Baselines are very wavy, sometimes going up and down, going to the hills, coming to the down, going to the, so hills, ups and downs. So this is called the wandering baseline. What are the causes of the wandering baseline? We are seeing the baseline, but you have to know what are the causes, right? So that we can correct it. So the complexes are there, but the baseline is not level. That's the thing. Baseline is not level. Here, muscle artifact baseline is level, but it's giving spikes. But here, the baseline is not level. It's going up and down. So complexes are there, but the baselines is not level. It waves up and down rhythmically with the snake-like motion. So it's a snake-like motion. It's going up and down. There is nothing constant for the baseline. What are the causes? Sometimes electrodes become very dry. Dangling lead wires means there may be some damage in the lead wires. Lead wires are the what is connected in the electrodes, or maybe it's not the connected properly with the electrodes. It's dangling. You think it's connected, but when you are clipping it, the clip is not proper. Loose electrodes. The electrodes that the pads you are giving on the chest or limbs is not sticking properly. It's loose, so connection is loose. broken lead wires. If there is any chips or anything is broken in the lead wires, you are going to see this type of wavy, snaky, all these baselines. But you will see the waves, but if the baseline is not right, how you are going to know that the ECG is right or not? So in that case, what you are going to do, no chance, you are going to use new electrodes or change the wires. Depending upon you see the electrodes is properly placed, it's not loose or anything, then then the option, there may be some change in the problem in the wires. So you have to change the lead wires. What is connected? What are the lead wires? Which is connected with the electrode with the ECG machine. So wandering baseline looks like this. The baseline is not complete. It's like the snaky, but you can see the proper waves. But if you cannot see the proper baseline, how you are going to measure what is the, how many is the positive deflection and negative deflection? Right?
Yes.
Okay.
Yes.
Respond to me, otherwise I think I am lost. Then we have AC artifacts. So far we learned about the muscle artifacts which cause from the somatic tremors, how it looks like. Then the wandering baseline is from the loose electrode, defective electrode, lead electrodes, electrode connections and other things. What is the AC electrode? AC artifacts. AC means its name's alternate name is 60Hz interference. Sometimes the questions comes as AC artifacts, or it comes as the name 60H, Hertz. Z is Hertz interference.
Hearts.
It
Okay.
okay. So appears a series of uniform small spikes. So baseline looks like a thick line. We are going to show the image. What are the cause? The electrical currents is nearby equipment or wiring can leak small amounts of electrical energy that ECG picks up. Sometimes your ground electrode, what you are pushing, ECG grounded machine are not equipped to filter out the electrical interference. Loose or broken ground connector or power cord. This is all the technical problems related to the ECG machine. So how it looks like. The baseline looks very thick. So current is not flowing properly. There is
Okay.
some problem. If there is sometimes strong phone, some other electronic devices, if your ECG machine is not grounded properly, so everything is going to cause like this hazy type of baseline. Is going to, if the baseline is also hazy, you can see the P wave, QRS, how we are going to distinguish between the S wave, T wave, because everything is very small, small, small. So each has alternating. AC is alternative names, alternating current. AC is alternate current artifacts. The current is not flowing. This is mainly due to problem in the ECG machine related, where is getting electricity to pick up. For there is interference. What type of interference? Maybe the ECG machine doesn't have poorly grounded, or if the ECG machine doesn't have the proper filter to segregate out the other electrical interference, the power cord may be not connected properly with the ECG machine. There may be some loose connections. So these are the causes of the artifact. So causes continued. What is the one of the ground electrode? We use the right leg. So right leg electrode improperly connected or not at all. Patient's bed, patient touching the metal frame. So patient is lying on the bed, or if you put the patient in the metal bed, it's going to give that a problem. Electrodes and cables tipped, corroded or dirty. If there is a dirty, it's not dry, it's dirty. So if some by chance the electrode drops in the floor, you are picking up and giving it to the patient. Or somehow you have something in the, you are wearing gloves or not gloves, if something is touched the electrodes or the electrodes come defective, is dirty. Or the cable tips, those are not loose or anything, is getting the connection, but it's not getting the proper connection. Corroded, if the corrode tips, where it is connecting is corroded or dirty. Solution, use 3 prolonged rounded outlet, 3-pin outlet, lead wires. Unplug other electrical appliances in the room table away from wall in turn of fluorescence lights. So all the things can happen. This alternating current we rarely seen because nowadays ECG machines are so good. Even you keep the cell phone, hearing aid, pacemaker, you will see the extra spike for sure. But other things, it doesn't show the alternating current. If it's really shown, that's the grounding problem, or maybe somebody has some high metal chips or devices which is picking the extra current. Filters. The filter on the ECG are used to remove high frequency muscle artifact and external interference. It will, however, cause slight adjustment to the ST segments. Most ECGs are done with the filter. ECGs has the filter on. So this is the thing, how the original waveforms look like and when it's filtered, how it looks like. This is not that important, but just to tell you. The electrical contact interpretation. What are the cause? The electrical contact may be cause. Spikes, obliterating tracing may appear in one or more leads, but usually not all leads. Sometimes here happen, you are getting the signals. You have 4, 6 electrodes and 4 limbed electrodes, right? In the ECG machine, it's going to show you, you are not getting, you are getting probably all of them only V6, you are that line. Why? Because the V6 electrode is not properly connected or not able to pick up the signals from the area you are going to connect from the heart to the machine. So what may be the electrode placement, electrodes may be dirty, maybe broken wire, maybe the connection problem, poor sensor contact. So broken wires, cables cannot be repaired, they must be replaced if there is a broken wires and cables. But if it's the electrode, you are going to change the electrode tip. So poor sensor contact, that is the contact is poor, that's why it cannot pick up the levels. AKA interrupted baseline. Sometimes it's happen like this. One graph is here, then suddenly it's go down and here. This is called the AKA interrupted baseline. This we rarely seen, very not so. This is the normal ECG. This is called the power line, that is the AC interference. This is the muscle tremor. This is the wandering baseline. You can see all are different. They may give you any kind of tracing and ask you what type of artifacts is that, or what the cause of the basic, if you have the snaky wave, or there is a connection problem, metal chips or this, and what type of artifacts you are going to see. If there is a patient has tremoring, what type of artifacts you are going to see. If there is a problem in the grounding problem of the ECG machine, what type of artifacts you are going to see. What is the alternating current, or 60H hertz the alternate current, or the baseline wandering baseline, or muscle artifacts. Pacemaker artifacts. Can you tell that ECG, someone has a
Yeah, I have
pacemaker?
question.
Gone?
I have a question.
Oh, question, not gone.
I mean,
Okay. Okay.
sorry, I maybe missed this one, but I just wanted to know what the AKA stand for.
To be honest with you, I am going to go through that. It says we know the AKA, so we just know that one. I am going to go through that and I am going to let you know. Okay. Thanks. Good question.
Thanks.
We
KA
don't-
stands for also known as.
Also known as AKA, yeah.
Yes,
Yeah,
AK.
as known as.
Also
Yeah,
known as.
Also known as interrupted baseline. So that means it has another name, but they also call it interrupted baseline.
So it's also known as?
Yes.
Okay, thank you guys.
I think we've lost her again.
Dismiss it, yeah. She gets
Okay,
disconnected.
let me try it again one more time. Okay, 1 minute. Drop the poll. Again. Okay. Okay.
Okay. So
Okay.
it shows in the pacemaker spikes. You can see vertical signals that represents the electrical activity of the pacemaker. And these spikes are more visible in unipolar than the bipolar spacing. See how it looks like. When there is a negative replication, you can see this pacemaker as a positive one. So P wave, then you see a spike here, and then it's going to the QRX complex, then it's going to the baseline. Spacing, that is called the stimulus artifact. That is tell you that they have a pacemaker implanted. How you are going to do the ECG? Everybody knows that. First of all, it's regular rule. Introduce yourself to your patient, ensure you have the right patient, do the patient identification. Always explain the procedure. You are going missing it when you are going to do that. Even for the blood work, explain the procedure and obtain consent. Ask patient to adjust clothing or remove from the waist down. Wash hands. PPE is not required if that is, but in hospital or everywhere, we just use the PPE, basic PPE. So I'm not telling you the gowns and other things, mask and other things should be wear always. If the patient is contact and isolation, you are doing the ECG, you have to do that, no choice. So patient wash hand, PPE is not required in lung. Patient should be reclining on a bed with a pillow, arms is not hanging. It's not touching on the side of any metal. Once electrodes are placed, cover the patient to maintain dignity, or you have to be in a room so that no one else is there except you and the patient. May need to shave if excess chest hair cannot be parted for electrodes. Get consent first. So who has the too much hairy chest? First, you are going to try to apart the hairs and try to put the electrodes. If it doesn't stick at all, you cannot get the ECG, then you have to take the consent. May I shave a little bit of your chest hair so that I can place your electrodes for the ECG? If they say no, you are not going to perform the ECG, you cannot go. If you don't get the consent, nothing. Then you have to report to your supervisor.
Sorry, regarding the consent, is it like a paper they sign or is it just verbal consent?
This is the verbal one.
Okay.
This is the verbal one.
Okay.
Okay. So you can ask a patient. If the patient knows, some people said okay, some people said no. Then I said okay, then let me talk to my supervisor and I will get back to you. That's all. You are not telling that I'm not going to do your ECG. You doesn't allow me. No. Let me go back to talk to my supervisor and I will go back to you. And then you can tell them to wait until you talk with supervisor and get back. If the supervisor is accessible or your doctor is accessible, immediately you can ask. If they are not, so you can tell the patient, okay, you can go back to your seat. I will call you later or I will update you later. Let me talk to my supervisor. Otherwise, sometimes if it's too hairy chest, you cannot put the electrode by any means. Then you have to shape the area because you need the contact with the skin to get the signal. So that's why I said, may need to shape if excess chest hair cannot be parted for electrodes. Get consent first. May need to clean the skin with alcohol wipe or soap and water if the skin is greasy. Most of the time you are seeing they are putting the electrodes and it's coming out. Electrodes coming out or electrode is there, it's not taking the proper signal. So sometimes if it is too dirty, it's going to give you this AC current artifact. Or it's not going to give you the electrodes is going to come out or it's not going to get the proper signal. So that time you have to, because if there is a lotion or cream or dirty, it's going to interfere with ECG. So you have to wipe that area with the alcohol to clean it. Quality ECG recording, you see you have correct patient information, baseline or tracing is smooth, Standardization mark is present. Inthoven's law is met. AVR lead is negative or downward reflection. R-wave progression is in the chest list. And R-wave means QRS, that is the R-wave, is going to in the chest list, in the V1, V2, V3. That should be there. Lead to a positive deflection. Lead to is going to give you the, what is the lead to is there, is going to give you the positive. These 7 points you have to remember, this question is going to come. They are going to give you 10 or 11 points, and they are going to ask you mark 7 points which you need to check for a quality ECG recording. Slide number 71. I'm telling you, you have to remember all those facts.
Okay.
Quality check, that's we have already told. You have to check all the parameters. Your patient name, ID is there, whether the lead 1, 2, 3 is there, what is the positive deflection, negative deflection, correct patient information. Okay, then baseline tracing is smooth. Third, standardization marks present. Okay, lead Inthoven's law is made 2 is equal to 1 plus 3. So you have to count it from 2 is equal to 1 plus 3. And then AVR is lead is negative. This is AVR is negative deflection. Okay, AVF is positive deflection. ROA progression in the chest lead. So ROA progression, this is the QR is progressing here. 1, 2, 3 chest leads. And what is called lead 2 is a positive deflection. This is the lead 2 is in the positive deflection. So these are the 7 criteria. Disposable electrodes we use, ECG cables. These are called the lead wires. These are called the electrodes. It can be like this. Ambulance or EMS use this type of electrodes. In office or in the hospital, we use this type of electrodes. This is called the lead wires. These lead wires, these are connected with this one, and then the other side is getting connected with here. So how is connected? This is the lead wires. They are all colored. They're connected here. And then it's going to go to a machine. So this is the general 3-channel ECG machine. In hospital, we use a different one. Or in the nowadays, we doesn't use this one. Reusable electrodes. This reusable electrodes nowadays. Okay.
Miss,
So
is
test your
it
knowledge.
different for kids and adults, the placement?
Placement
of
is
the-
same. Placement
Okay.
is same. Only you have to cut the electrodes in half, because their chest area is so small. That's a good question. I really appreciate that. So that time you have to cut the electrodes in the middle in the half and put it in the same position.
Okay.
Otherwise, it's going to cover their whole chest. The position is going to be the same.
And what's the age range when you like stop? Like, is it 6 and above, or you from 6 and below, or 10?
It is your judgment. So if it is 1 year, 2 year, times if the baby is built up, you can well built, you can use the proper electrode. For the newborns, 5 months, 6 months, we have to do the half electrodes.
Okay, thank you.
Okay, so you have to see the baby up to 2 years is okay. We can push the half. Then after that, generally it's okay to put the full electrodes. But it will depend. If the baby is very skinny, then you have to take the judgment how you are going to do that.
Okay, thank you.
Okay. So this is test your knowledge, why it is important to minimize external sources of electricity before running an ECG. Why?
It could cause a disruption, artifacts, and just completely mess up your test.
Yeah, it's a problem in the electrical interference, mainly the AC currents, okay? Electrical currents, mainly the AC one. Okay, what should you do if patient refuses the ECG procedures?
And go
Document.
We tell our supervisor and
The
we'll get back to
supervisor.
the patient.
First, you have to ask the reason for refusal, okay? First ask the reason for refusal. Try to, if the patient said, oh, I like to lie down on the bed. Oh, I like to sit on the chair. Oh, I don't like to take out my pant. So If you said that, okay, take out your dress and wear your apron. So no, I don't like to take out. So first ask the reason. Further, if you can fix the problem. If not, you have to report the supervisor and document the patient refusal, because that's why you have to ask why the patient is refusing. Okay?
Okay.
Okay. Which anatomical landmark starts in the middle of the axilla and runs down the side of the chest? Middle of the
With
axilla.
auxiliary line.
Line.
Which electrode we place there? Mid axilla?
It's about
Four.
V4,
V4.
V4, or
Mid
V5,
axilla.
both.
Mid axilla.
V3.
V1.
No.
No.
Those are the mid
axilla.
clavicle.
sorry.
V4 is mid clavicle.
It's
V4.
V6.
V4 is mid clavicle.
V6.
V6.
V6. Fix. And anterior axillary, which number electrode?
V1.
Anterior axilla.
V5.
V5.
V5, yes.
Right side of the fourth intercostal area.
V1.
V1.
V2 is placed in where place?
Left side.
Left side.
Left side of what?
Between 3 and 4th. Rib cage.
No.
Or
What intercostal area?
Fifth.
V2.
The fifth.
Before mandible.
V3 and
Below the mandible.
V3.
I think it's V4.
The fourth.
B, yeah.
So it's V2 and fourth.
mid axillary line.
Yeah, it's V4.
Mid axillary line, yeah. No?
First one.
Miss Mumun?
Oh, we lost her again, guys. Oh my god. Okay.
Yeah.
Let me try.
Okay, I'm gonna go, but I'm gonna be on. I hope I can get this. I can get connected on my phone. I'm gonna try and disconnect off the computer because I gotta go now.
Yeah. Okay, sige.
I'm gonna still be online. However, I'm gonna be driving. So
Yeah.
thank you guys.
Okay, take it easy, Asnet.
Yeah, take it easy.
Yeah, thank you. I will try my best. No rush.
Okay.
I guess she's going to chapter 3 after this.
Yes, I believe
Two,
so.
right? Gotta get that one. Oh, my right is here. All right, guys. Bye.
Bye.
Bye, see you later.
See you later.
I connected her, but I don't think it went through. Let me try that one more time. Oh, it's still calling. She was asking about V4, right? Where that's located?
Yes, I
V4
believe
is
so.
down the,
It's in the mid clavicle
Yeah.
line.
Mid clavicle line, yeah.
The vertical line starting from the midpoint
in
of
the
the
mid.
clavicle. Yeah.
Yeah.
I thought she was talking about V1 and V2. I find being online so overwhelming and confusing.
I know. And
Yes.
it kind of just like lags off her voice today. So we kind of miss like, okay, V1, suddenly she goes to like V3 and we're like, oh, it's this.
Headache.
Yes, big
know.
headache.
Okay. But okay, let me try again because somehow she still got dropped again.
Oh, okay. Thank you, Shabana.
No worries. Okay. Yep.
She's in.
Yep. Okay. we
Okay, so
got it.
there are a couple of test of knowledge questions that you can check by yourself.
Okay, ma'am.
Okay, so that you can test by yourself. So is the what is the different, what am I asking? So what is going to put the V1 electrode, where you are going to V2? It's not easy. You have to write it, read it, and then you can answer. So there's a
What are the most common for? Okay. Oh no, I think she got dropped again. Yep. I think the connection's so bad, we can technically just get her to do it on our WhatsApp group, and then we can just go through the slides.
Yes, that's true.
Because this is not working out anymore.
Yeah.
Yeah.
And we have like technically an
I-
hour left.
That's
Yeah.
right.
But she is done with the slides almost. There's only 3 more slides left.
Yeah.
So let me try one more time, and then if not, I'll give her a call.
Okay.
I also heard the connections are going to be really bad on the 8th during this solar eclipse.
Oh, wow. Really?
That's what the news said. I was reading about it this morning. It said that there's going to be no connection for any of the providers.
Oh, wow.
Yeah. I sent it in the group so you guys can read it.
Okay. Thank you.
I'm connecting.
But today is very windy too. They were saying it on CP24 that it will probably disrupt
you're
the
in?
connection. Oh,
Yeah,
she's
that's
here.
right.
Okay,
That's
she's
right,
in.
Christiana.
Yeah.
For the next few days, actually. It's quite
Yes.
windy in our area now.
Me
Yeah,
too.
it
It's
is.
very
It's
windy.
so I am in and out. I don't know what is happening. You can hear me now?
Yes,
Yes,
ma'am.
Yes, ma'am.
Okay, so basically these you can test your knowledge, okay? What is the alternate current artifact? So these you can do that one. So we are done for this one. Let's me then. This is, yeah, this is the almost end of the thick slides. What is the next one? Let me see. What? Oh, so this is you have to also do by yourself. So let me see. Simulation. We did the PowerPoint. This one you have to do by this one, okay? Schematics, explore. You have to. What is this one?
This video demonstrates how to set up and perform an electrocardiograph.
So basically, these you have to
ECG.
schematics you have to do at home, or
Equipment
you can do
required
by
includes the
yourself right
following.
now, okay?
ECG alligator clip.
Okay, ma'am.
You can hear me?
Yes, we can hear you, ma'am.
Yes, ma'am.
Okay, so that you can do that one instead of getting interrupted. So that you have to on your screen, and you have to learn, and there are some activities they are going to ask there. It's called the simulation activity. Then is the life lab. Is going to tell the life lab how they do the ECG preparation for the patients and other things. So this is also each one you have to go through that. This is for your assignment for the homework also. Okay, life lab is done. So this is life lab, electrogram, this one done. Then we are going to see whether you can watch the video.
So in a 12-lead ECG, we are provided with 12 views of the heart. So how does this come about? Because we've got an electrode on the patient's left leg and on their right leg, on their right arm and on their left arm. And we have, as we'll see later, 6 chest electrodes. 6 electrodes on the chest. So if we've got 6 pickups on the chest, 6, 7, 8, 9, 10, that gives us 10 leads, but it's called a 12-lead ECG. So how do we explain the fact that it's a 12-lead ECG? Well, what we can imagine is what is called Eindhoven's triangle. An Eindhoven's triangle is just that, it's a triangle. There's an imaginary line going from there to there like that. That's one side of the triangle. There's another line going from here down to the left leg, down to the foot, which is there like this. And there's another imaginary line of the triangle going up here to the left arm. And as you'll notice, the right leg is ignored altogether. And the reason for this is the electrode on the right leg is just an earth. It's not a detecting electrode, it's just an earth. So what we have here is an electrode on the right arm, an electrode on the left arm, and an electrode on the left leg, which we call the foot. Now, we're picking up electrical impulses from here and electrical impulses from here. And these are going away into our clever ECG machine. And as you know, the lead on the 12-lead ECG is 1. Lead 1. Now, what the ECG machine does is it's very clever, and it takes part of the information that it's picked up here, part of the information that it's picked up here, and it cleverly and electrically combines it into one view. So lead 1 is called a dipolar lead. There's 2 poles. So information is picked up from there, it's picked up from there. The machine splices this information together and gives us lead 1. And what this actually means is lead 1 is looking at the heart from on top. So if we think that the heart is about here, somewhere around there, then lead 1 is essentially looking at the heart from this direction. It's looking at it from on top. That's lead 1. Now, lead 2 is another dipolar lead. And again, this clever ECG machine is taking some of the information from the right arm, some of the information from the foot. It's combining that electrical information together in a clever way. Essentially gives us a view which is combining this and this, and essentially is giving us a view from lead 2 in this direction, towards the heart from that direction. So it's giving us a second view. That is lead 2. And lead 3 is the third dipolar lead. Again, information is taken from 2 electrodes, from this one and this one. It's cleverly electrically combined in the machine. So lead 3 is essentially looking at the heart from this direction. So we have a third view of the heart. So leads 1, 2, and 3 looking at the heart from different directions using bipolar electrical information. Now the next view is AVR. And AVR is looking at the heart from the right arm. So it's essentially looking at the heart in this direction. So again, that's another view. Now the AV stands for augmented voltage right, because again, the machine is adding a bit of voltage to this. Now the voltage is already there, it's picked up here. But the way I think of it is because it's a long way from the heart, it needs a bit of a boost. So it's augmented voltage right, looking at the heart from this side. And this is just
There's no sound. Again, ma'am.
She got her connection dropped again.
Yes.
Come on, you guys. She's not getting connected. Okay, she's not connecting at all. It keeps getting dropped.
Hmm.
Let me try again one more time.
Guys, what are the assignment that you want us to do?
It was on your thing, isn't it? It's
It's on the
V2L.
Okay,
Yes,
no problem. I'm
it's on
driving now.
V2. Yeah, it's
Okay,
on
no problem.
V2L. And if you need any information, you can message me later. I'll tell you which ones
No
exactly.
problem. Thank you so much. Appreciate it.
No
Thanks.
problem. Okay, guys, she's not connecting at all. Should I just call her and then see what the situation is?
Sure,
Yeah, I
Shabana,
think
if you
so.
can.
Okay, I'll drop her a call and see.
Okay, thank you. Guys, check your
So should
WhatsApp.
I tell them all to connect on the WhatsApp group? Okay.
Yeah, that's awesome.
I don't know. It's running the YouTube video, only the connection in the team. What is the problem?
It's okay, ma'am. We will go from here.
So it's augmented voltage right, looking at the heart from this side. And this is just a one pole view. It's a unipolar
You can see, right?
electrode.
Now you
Yes,
can see.
ma'am. Yes,
And the next
ma'am.
one
We can
after
hear you.
AVR is AVL.
Yes, ma'am. Thank you.
So AVL is augmented voltage left, and that's again unipolar, and it's as if it's looking at the heart through the left shoulder. It's looking at it from this direction here. So again, that's giving us another view of the heart. And then the next lead, the sixth lead, is AVF. That stands for augmented voltage foot. Again, it's a unipolar electrode, and that's looking at the heart from this direction. So you can see we've now got 6 views of the heart. We're looking at it from 1, from 2, from 3, from AVR, from AVL, and from AVF. We've now got 6 views to give us anatomical positional information of what's going on. And then, of course, we've got 6 chest leads. So we've got V1, V2, V4, V6, V3, and V5. So we've got V1, V2, V3, V4, V5, and V6. And these are looking at the heart from a plane going around the heart that way. So these ones are looking at the heart in this, the 1, 2, 3, AVR, AVL, AVF looking at the heart in this direction, in this plane. The chest electrodes, V1, 2, 3, 4, 5, and 6, are looking at it in this plane. So we've got a lot of positional information about the heart here. So, for example, if someone has an inferior infarct, that can be seen on the inferior leads. So if the infarct's at the bottom of the heart, that's going to give ST elevation on leads 2, 3, and AVF. They're the leads that see the bottom of the heart. They're looking at it from the bottom. Or if there's an anterior infarct, that's going to be these leads V1, 2, 3 are on the anterior surface of the chest. They're looking in that way. So if there's an anterior infarction, we'd expect to see that on leads 1, 2, 3, maybe 4. If there's a lateral infarct on the side of the heart, we'd expect to see that looking from the side, and the leads from the side are particularly V5 and V6. So we have 10 electrodes on the surface of the patient's body. We need the earth, but we can take that away. But then we have 1, 2, and 3 as well, giving us a total of 12 views of the heart, giving us essential anatomical information. For example, if it's an inferior infarct, then the thrombus is most likely to be in the right coronary artery. In 80 or 90% of patients, it'll be in the right coronary artery. If there's an anterior infarct over the front of the heart, that will most commonly be a thrombus in the left anterior descending artery, in the LAD. If there's a lateral infarct, that will tell us that the thrombus is most likely in the circumflex branch of the left coronary artery. But all this information is only available because the 12-lead ECG gives us anatomically accurate positioning information.
This video is very useful. You guys can look again.
Yes, ma'am, that's true.
Very
Yes,
useful.
it does.
Yeah.
So, ma'am, it's called a 12-lead ECGs because it shows us 12 different views. Oh, no, never mind.
10, I guess.
Yes, that's how I take it.
I thought because it's showing us 12 different views, right? The arrows were
Yeah.
12 arrows.
Yeah, that's right.
Okay.
That's right, Shivana.
I think she's gone again.
I know.
Yeah.
I'm going to connect her again.
Electrocardiogram, as indeed does EKG. So in the States, there's a tendency to refer to EKG. In the UK, we would call it a ECG. But it's exactly the same thing. The K actually comes from the German for cardio, because I think these machines were invented in Germany. And also the K is consistent with the original Greek as well. So whichever you call it is fine. Now, I often get asked about the PQRST. They don't stand for anything. They have no meaning. They're completely arbitrary letters that are assigned to these different waves. That's all it is. There's nothing significant about that. So we start off on the isoelectric line. Now, iso means the same. So here we don't have any significant electrical activity. But then we get electrical activity in the form of the P wave. Now the P wave goes up and it goes down. So all of that in green is the P wave. The bit that goes up and the bit that goes down. And as we see, it goes back down to the isoelectric line just here. Now what's happening here with the P wave is the P wave is caused by the depolarization of the atrial myocardium. So in the myocardium, there's lots of individual cardiac cells, lots of individual myocytes. And at rest, these are going to be negative inside, about 90 millivolts negativity. So there's more negative ions inside the cell than outside the cell. And when it's at rest like that, we'll say that that is polarized. So that is the polarized cell. But then when it depolarizes, that's all going to change. So when it depolarizes, it changes to become positive on the inside and negative on the outside. So here it was negative inside and positive outside. The depolarized position is the opposite. That is depolarized, and it'll actually depolarize to about plus 20 inside for a period of time. Then it'll be about plus 10. But what we see is it's polarized there and it's depolarized there. And the important thing about this is that it's the change from being polarized to being depolarized that initiates the muscle contraction. That's what triggers the initial muscle contraction. So the muscle's sitting there in a polarized state, then it depolarizes, and that's what stimulates the contraction. Now, that's the P wave. The next thing that's going to happen is there's going to be a Q wave, and that goes down and it goes back up to the isoelectric line. So that is the Q wave in yellow. And again, we see it consists of a downward deflection and an upward deflection. And then it's the P wave that carries on as the large upward deflection, which is the R wave, up and back down to the isoelectric line. So everything in red is the R wave. And then after that, this line actually carries on below the isoelectric line and then goes back up to it. So it's P, Q, R, so that's the S wave there. And again, we notice the S wave has got this downward deflection followed by an upward deflection. And then we have a little more isoelectric line here. And then we have the final wave. Well, we normally count it as the final wave, which is the T. The T wave. So P, Q, R, S and T. And again, we notice the T wave is the upward deflection and the downward deflection. That's what counts as the T wave. And then we have some more isoelectric line prior to the next P wave. Now, we've said it's the depolarization of the muscle that causes the contraction. So this depolarization here is going to stimulate atrial contraction, and that's going to go from about there to about there. So this period of time here, from the P wave to about the middle of the QRS, is when the muscular contraction of the myocardium, the atrial myocardium, generated by the depolarization of the atrial myocardium, is taking place. So that's the depolarization. That's the time when the contraction takes place. And when the muscle is contracting, we call that systole. So this is the period of time of atrial systole. Now, the QRS complex is the depolarization of the ventricular myocardium. And the depolarization of the ventricular myocardium will initiate the contraction of the ventricular myocardium, which will take place during this period of time here. So first we have atrial systole, and then the contraction of the ventricular myocardium, ventricular systole. And all that muscle contraction is stimulated by the depolarization. But of course, in order to contract, the individual myocytes need to depolarize. But of course, they can only depolarize when they're in a polarized state. This can't depolarize again because it's already depolarized. So if we want another muscle contraction, and we most certainly do, and another 0.8 of a second or so, can you see this has to go back? The depolarized has to become polarized again. It has to change from being positive on the inside back to being negative on the inside. And that process is called repolarization. Because only when it repolarizes does it become polarized again, because it can only initiate contraction when it changes from being polarized to being depolarized. So we're now in a position where we can have another cardiac contraction. So P in green, Q, R, S and T, all in their relevant colours. And what confuses a lot of people is that the wave is the upward deflection and the downward deflection. Or here, the downward deflection and the upward deflection away from this isoelectric line. Iso just meaning the same. Now, we often talk about a sinus rhythm. And a sinus rhythm is generated by the sinoatrial node, the pacemaker of the heart. And a sinus rhythm has got a P, Q, R, S, T in the right order,
and is fairly regular. If there's a P, Q, R, S, T in the right order and it's fairly regular, but the rate is below 60, that is a sinus bradycardia. It's still initiated by the sinoatrial node, it's still fine, but it's below the rate of 60, so technically it's described as a bradycardia. If you've got a P, Q, R, S, T in the right order and it's fairly regular, but the rate is above 100, that is a sinus tachycardia. They're the three normal rhythms: sinus bradycardia, sinus rhythm, sinus tachycardia. And this is what we've drawn actually here is a cardiac cycle. So the atrial systole takes about 0.1 of a second, and the ventricular systole takes about 0.3 of a second. If we assume the whole cardiac cycle is about 0.8 of a second, as it would be if the heart rate was around about 74 beats per minute, which would be fairly normal. So we see that the P wave in health can be considered to be the same as the atrial contraction. We know it's not quite the same because the atrial systole actually comes a little bit after. And we can consider the QRS to be the same as ventricular contraction. We know it's not quite the same because it goes a little bit after. But in health, the depolarization will always trigger the contraction. There's only one exception, and it's not in health, it's by no means in health, but there's a very dangerous cardiac arrest rhythm, and it's called pulseless electrical activity. And in pulseless electrical activity, you get this electrical activity in the heart, but it's not associated with any contractions. The muscle is depolarizing, but the myocardium is unable to respond kinetically because of severe problems such as exsanguating hemorrhage. That would be the only exception, pulseless electrical activity. Apart from that, P is atrial, QRS is ventricular, and T is repolarization of the ventricle. Now, we've said that the T is the repolarization of the ventricle, the ventricular myocardium, which we see here, the repolarization. So P is depolarization, QRS is depolarization, T is the only one that's repolarization. So obviously, we're going to need a repolarization of the atrial myocardium, but we don't see that. Well, that's because there's so much electrical activity going on in the QRS that the repolarization of the atrial myocardium, which of course takes place, it has to take place, but we don't see it because it's buried in the QRS complex. But there will be one, there has to be, otherwise the atrial myocardium couldn't depolarize to generate the next atrial systole. Now, with practice, these ECG readings can tell us all sorts of things. We can do positional ones called 12-lead ECGs. They'll tell us about the normal conducting pathways. They'll tell us about heart damage. They'll tell us if the heart is enlarged. And they can also tell us what's causing myocardial pain. So well worth learning the basic PQRST. And then with experience, you'll realize that this has lots of implications for pathology, patient assessment, and patient management.
You guys can hear me now, till now?
Yes, ma'am, we can hear
Yes.
you.
Okay,
Yes.
let me see what is the next one.
Miss, I had a question. In one ECG, like a successful ECG reading, how many times does it have to polarize, repolarize, and polarize, depolarize, and repolarize? Is there a number of times in a full scan does it take place, or is it just random?
I don't get you.
You know the waves that are made right? Like
Mhm.
the PQRST. How many times does that show up on the paper itself that we put
It
in?
depends on the paper length and how the ECG is going on. It's not like the exactly how many times is the normal. If somebody has a bradycardia, tachycardia, anything else is changes. So yeah, it's also the depending on the ECG paper, ECG machine, everything. In general, what I will get in my hospital, I will tell you next time when I'll do that in general. But in my hospital setting, that will tell you. But
Okay, ma'am.
yeah, exactly. Okay, so let me see where we are. But it is going to be the complete, you have to see the complete cardiac cycle, when it's repeating, whether it's uniform or not, if there is any problem. So it's going to show you. So this is, we saw this one. This one we
So in the
did.
12 lead ECG,
Okay. So what we are going to tube lead ECG before that. This is the simulation activity. Live labs. Then this is the simulation. Then what is before that? Okay, so unit 2, this one we did, libelous video is done. Okay, so next KCG heart unit 2 we did, unit 3. Just give me a second. Hello?
Yes,
Hello?
ma'am. I can hear you.
Yes, Miss, we're
I can
listening.
hear you, ma'am.
Okay. Who is that?
Kara?
Okay. So, faltu phone call. Okay. So next unit 3 is tomorrow. It says the ECG assignment. So it's nothing has to do with me in case we have the what is called the ECG assignment. Let me see. Instruction. Okay. So you learning material including online test from D12 to answer the following questions. This is an independent assignment will be completed during class time. It will be marked out 30 and is of 30% assignment. Is there anything they told you? Okay. Electrical machine 30 minutes. Questions. So you guys have the questions here, okay?
Yeah, okay, ma'am.
Okay, so you have to do the time 50 limits, task quiz, and once you're done, it's going to come to my, and once you're done, let me know, then maybe we can see the grades. Okay, so this is the 30% grade for yours. So this is for tomorrow's activity. So tomorrow, let me see what is happening. So tomorrow you have the ECG assignment to do in the class. In case the internet problem again, you guys can do this one. So electrocardiogram is done. Okay, so this one is done. Unit 3. Okay, instructions. So this is the ECG assignment. And what is this one? Retrieve from readings. What is the readings? What is it's going to be from your side? So this is also you can have beautiful, image of a heart. This is the reading materials. You can go through this. It's going to help you how to do the depolarize. Depolarize is little bit hard, but you can, if you want, how it has the depolarize and repolarize the cells, how that video is showing. It's not easy for you guys, but you can go through this one. It's just a little bit high level. Okay, then you need to overview. We did this one is done. Then unit 3, we have the assignment. That's the unit 3. And the next one is unit 4. So alter diary, alter monitor. How many slides are there? Only one? No. Oh, come. This is, unit 3. Unit 3. This is unit 3. Okay, so I have to go to unit 4. Unit 3 is for tomorrow. Telemetry PowerPoint. PDF telemetry PowerPoint. How many slides are there? So tomorrow, if possible, if the internet works properly, so maybe I'll go to the Holter monitor, okay? You can do your assignment first tomorrow. You read everything today morning. By 10, you can complete your assignment. It's not going to be too much. So once your assignment is done, we'll be online from 9, but we can start the teaching. But by this 1 hour is 50 minutes. So even you start at 9, it's going to be done by 10. Even I'm giving you 10:30. Okay. So if somebody comes late or something, within 10:30, we start at 9 a.m. in the team will join. If there is any internet problem or anything, you guys can start your ECG assignment. Okay. You can finish it, and around 10:30, we are going to start our teaching again, so that if we can do the Holter monitor, then you are going to get 1 day time for your review. Group review or Sadati, so that you can do the test on Friday.
Okay, ma'am.
Okay.
Yes, ma'am. Thank you.
Okay.
ma'am.
Okay.
Thank you.
Okay. So yeah, you guys can continue your study or anything. If you have any questions so far now,
No, ma'am, we're good for now. Thank you.
good for now, but try to use the law this Friday.
It's Friday.
Test 1 this Friday.
And regarding the assignment,
I know, but Luis, what I can do, I cannot help anything about that, but we are running in shorter time. I cannot postpone everyone's exam for next day or this or that. I was getting, they are questioning me why I'm doing so much.
yeah.
That's you can do. That's better. You can start at 9 or 9:30. You can do the test, and then Naga Pulse is not too far. That's a good idea. Then we'll be totally free. That's why I'm giving you the time on Thursday to review whole. So I can complete the Holter monitor. You can do the ECG assignment tomorrow by 10:30. Okay. And then I can go to. Yeah,
Yes.
I'm giving you the class because I know you guys have to read. Otherwise, how are you going to do the assignment?
True.
You have to read today, right? Even you can start around, if you want to start at 9:30, so you can 9 to 9:30, you can the review, 10 to 10:30, you can take the exam. Or even if you want to do the assignment, complete the assignment 11, then I can complete the Holter monitor by, you can take the break 11 to 11:30, and then from 11:30 to 1, we can complete the Holter monitor.
Okay. Yes, ma'am.
So maybe we can start teaching at 11:30, but be on team at 9. You do your studies, whatever the lab, then you take the test from by 10 is 1 hour. So it has to be 9:30 to 10:30.
Okay, ma'am.
Or by 11:30, we can just meet again. 11:30 or 35, we can meet for the class, the Holter monitor. In fact, complete the Holter monitor is not too much complicated. Mainly complicated part is done. Then I like to give you the times, because I know you guys are not going to get time at home to read it. In class, you are bound to do that.
Yes, ma'am.
Yes.
Yes, miss.
So in the class, you are going to, on Thursday, you are going to do the whole review, and the Friday, we can take the test at 9:30.
Ma'am, on Thursday, can we just like study amongst ourselves and like share our answers once everyone's done?
That is your choice. You guys talk in group whether you want to do group study, or if you can do the, okay, group 1 can answer where I have sent you the reviews. You can make all the answers, then you can do in the, you have to be on team, right? So you can ask the questions and answer. I'm going to be with you, but for test 1, I'm not going to give you any answer, as I do.
Yes.
Okay. Yeah. But we can discuss amongst ourselves and then just do the test and then
Like before.
But
yes.
What I am telling you, first 1 hour you complete between the group discussion. Next hour, say from 9 to 10:30, you do the group discussion. Okay. Whatever I feel, then you guys can decide whatever best way to you guys. 10:30 to 11, you take the break. Okay. 11 to 12, you do your own review, whatever you have studied in the group. Okay.
Yes.
Okay. Then 12 to 1, you cross each other.
Okay, ma'am.
Yes, ma'am.
Yep.
Yes, ma'am. That sounds good.
You will be there. You cross each other so that suddenly one question you ask, in the class and you can say Evelyn ask the question to Savannah. Savannah is going to answer. Even Savannah cannot answer, then the next person can raise the hand and answer. Then Savannah can understand what she did the mistake or what the. So again, Christiana can ask question another one. So that way you guys are to know what I am asking the question. This time you can ask the questions among yourselves.
Yes, ma'am. Okay.
Yes, ma'am.
If I
Yes, ma'am.
see any really wrong answer, then I will step in.
Okay, ma'am. Thank
Okay,
you.
ma'am.
Okay.
Okay?
Thank you.
Yes,
Okay.
ma'am. Thank you.
Okay,
Sounds
so
good.
tomorrow again, I don't know, this rain, this garbage weather, internet problem. So
Yeah.
anyway, you guys start your reading and your assignment. You done by everything. By then, from 11:30 or we are going to meet for teaching. Okay?
Okay, ma'am.
Okay.
Yes.
I will be
Thank
on
you.
team, but I'm not going to interrupt you or talk you. You can see, but if you see I cannot join, again send me the links and we're going to join it. Okay?
Okay.
Okay. Thank
Thank
you.
you.
Okay. Bye.
Okay,
Thank you,
ma'am.
Miss.
Bye.
Bye,
Bye.
ma'am. Bye,
Sorry
everyone.
for today's interruption, but it is not in my hand. Also, you guys understand,
It's
right?
okay.
And thanks for
Yes.
every
Okay,
time
ma'am.
connecting me. Sorry
No
for all the
problem. It's
troubles.
okay.
Okay.
Yes. Thank you,
Okay.
Shabana.
No
Thank
Okay.
you.
problem.
Yeah,
Thank
thank
you.
you.
Thank you.
Thank you.
Okay,
Okay.
guys. Take
Okay.
care. Bye.
Okay. Bye-bye.
Bye.
Bye.
Bye.